Well, to begin this panel, what we're going to do is Jim is going to give the overview of the presentation, and then Jeff is going to talk about the legal, and then I'll wrap it up with the political perspective. So I'll introduce Jim first.
Thank you, Ron.
Thank you, Ron. It's a great pleasure to be here, and I thank you all for inviting me to participate in your session here. So I'm looking forward to share what little bit of knowledge I might have relative to the effort that you all have underway, and I think it's a very exciting time for you. I'm a member of the Hopi tribe, an enrolled member of the Hopi tribe, and on my father's side, I'm also a tribal member from the Fort Belknap Assiniboine community in northern Montana. Over the last 25 years, I've worked in Indian intergovernmental affairs, specializing in economic development, and for the last 15 years working in healthcare. My education by training is in business administration and economics. So I've been around the self-determination movement. At least my father participated and was really involved in the process in tribes taking over management of their educational programs. So growing up from the time I was about 14, 15 years old, I've been around this very dynamic process and have heard tribal leaders like Ron and tribal leaders that are in the room talk about this process. And it really is a very interesting time. It seems daunting at times in terms of some of the task before you. But my experience and observations over this process is that when tribes or Indian people take management of their own programs and services from those that others that provide them supposedly on their behalf or in the benevolence of their behalf, what you end up with is a much better system. You know, there's a lot of growing pains that happen along the way, but I think as Ron and Jeff will attest to in the course of their discussion, the outcome is much more beneficial than likely what you have today. So I encourage you all to stay committed, stay on task, and stay together. You know, there's going to be a lot of processes or institutions that try to divide and conquer is the term that we use in our country to try to, you know, throw obstacles and barriers to the process. So what I'm going to do is I've got a presentation, and after I heard the discussion yesterday, I really didn't have a plan to do a presentation. I was going to just talk from experience, and but there were some things, there are some questions that were asked and some things that I thought I needed to clarify, you know, in terms of the discussion from our experience relative to what it is that you're all doing. Talk about some of the budgets. There were questions about you know, money and budgets and that type of stuff. And then kind of just talk a little bit. I've got another presentation that shares with you tribal perspectives in self-determination and self-governance. And this was a study that I was involved in when I was at the National Indian Health Board, where I also worked at for a number of years, for 7 to 8 years in Washington, D.C. The organization's now in D.C. I worked with NHB when they were in Denver. But this study was the first quantitative effort to try to look at the outcomes that resulted from tribes taking over management of their health programs. And there were some very interesting findings in that process that demonstrated kind of the points that I've already made earlier, is that when tribes take over programs, Indian people start operating programs that are operated on their behalf, the outcome is much different. So I think I have a clicker up here somewhere.
Oh, yeah, dropped it on the floor.
Okay.
Oh. Yeah. Sorry, I hit it. By the way, NIHB, National Indian Health Board, not non-insured health benefits.
Oh, okay. Yeah. So, and that's a good point. I'll explain a little bit about our organization and kind of what it is that we do. In the course of my discussions with some of the health directors and tribal leaders here, they were very interested to hear about what our organization does and how it relates to the National Indian Health Board. Not your version of the NHB, but our version of the NHB. So, this first slide kind of explains a little bit about the Indian health system. So our system has been around, of course, for very long. You know, the health services for our country were first established within the Department of War for obvious reasons. Eventually, they were transferred to a number of different agencies. And in about 1955, responsibility for health care services was transferred from the Bureau of Indian Affairs to the Indian Health Service. And the enabling legislation that cleared the way for this to happen was what we call the Transfer Act, and that happened in 1955. Interestingly, once the transfer of the programs went over to establish the Indian Health Service within the Department of Health and Human Services, that's shortly following that is when we saw a marked improvement in the health status of American Indian Alaska Native people in our country. So I thought, so the Indian health system oversees healthcare services to about 557 federally recognized tribes. Now, at the time I developed this slide, which is a couple of years old, we've had several new tribes come in and be recognized through the federal recognition process. So, there's, depending on the source of information, this number varies from 557 to 565 federally recognized tribes. It just depends at the point in time, and I haven't updated my slides, so maybe this is a good reminder for me to do that when I get home. So this system encompasses over 1,100 healthcare facilities throughout 35 different states. So it sounds like it's very comprehensive on its face, but some of the things that I'll talk about later on about financing issues, while we might seem comprehensive, we are severely underfunded, and that's a challenge that you all are going to have as well, is determining how you measure your level of need relative to carrying out your mission. And we've got a process that I'll share with you later on that allows us to do that. That process, that equity issue that we came about really it wasn't developed at the onset of tribes taking over their system. It was developed in the midstream as somewhere in the midst of 20 years or so ago that gave us, we realized we needed some way of measuring financing relative to tribal programs across the system. So these 1,100 facilities, about 50 hospitals, 500 to 700 health clinics and ambulatory facilities, 133 health stations. These health stations are usually in community settings, either in recreational halls, schools, some community environment, just usually a public health nurse of some type, providing very basic community health service. As well as about 170 Alaska Native village clinics throughout Alaska. We also have 34 urban Indian health programs that are located in big cities in our lower 48 that have a significant Indian population in them. The way that our system is organized is it's organized into what we call 12 area offices. These administrative units oversee health operations for the tribes in that region. So we call these units area offices, and then where I'm from, I'm in the Portland area. We have 43 tribes in our area, 29 tribes in the state of Washington, 9 tribes in Oregon, and 5 tribes in Idaho. This map here kind of explains the administrative system. It shows you the organization. Of course, in the northwest there, Portland area, as I indicated, 43 tribes. The California area has 108 tribes in their area. So it kind of gives you a basis for the number of tribes in each of these administrative areas. The Billings area, for example, again, has 9 tribes in their area. The Aberdeen area, I think, has approximately, I want to say 28 tribes, but so the size of our administrative units varies across the system, even down to the Tucson area. If you look way south, right above Alaska, of course we had to put Alaska in the ocean because we couldn't fit it in the map here, but just above Alaska there is the Tucson area, and the Tucson area only has 2 tribes. So there's great variation, and if you look at the geography of the Nashville area covers about 28 different tribes. I'm looking at Jeff because I know that you said it's a client to his, so but they have a tremendous geography with a number of tribes, and they have almost the eastern part of the United States. So it kind of gives you an idea about the organization and structure of our Indian health system. Now, I know Jeff is going to talk a little bit more, and Ron are going to talk about the Indian Health Self-Determination Act, but I think it's important to note just how it's resulted in the management structure of the Indian health system under points that I'm going to clarify here called contracting, compacting, and direct service. So this is a key piece of legislation, probably the most important legislation in the history of Indian health policy for the United States as far as I'm concerned, that allows tribes to take over programs from the federal government, very similar to what you're talking about here in the room now. The process by which this happens is through contracting, which for the most part means that when a tribe takes over a program from the federal agency, the Indian Health Service, they have to pretty much mirror image the programs and services under that contract that the agency would have provided for itself. Shortly following, somewhere in the process of Indian self-determination, there were amendments to the Self-Determination Act that allowed for a program called the Self-Governance Program that Ron is going to speak about. But the Self-Governance Program is an extension of contracting or self-determination that allows tribes entering into a compact arrangement with the federal agency to take over the program and restructure and redesign it. It gives them greater flexibility than a contract might. So that's important. I don't want to get too ahead of the presenters that are following me, but it's an important distinction to make as I'm going to explain these terms to you. The Indian Health Care Improvement Act, also as Harold just mentioned, was recently reauthorized in the Affordable Care Act, so our version of the health reform bill that's going on in the United States right now. But the Indian Health Care Improvement Act sets up the programmatic structure for the design of the Indian health system. It sets up programs for hospital and clinics, dental programs, behavioral health programs. It has some wraparound services related to health promotion, disease prevention components that include community health representatives, public health nurses, and then also has a facilities program for facilities construction, sanitation services, environmental programs. So taken together, the Indian Health Care Improvement Act and the Self-Determination Act set up the basic framework for how our system gets developed. Some of the terms that I heard yesterday that might be foreign to you, and at least I learned yesterday, are contracts and compacts. And I explained a little bit previously, just a moment ago, about what contracts and compacts are. You can think of these being the same thing or equivalent to what you all have been using in terms of transfer. Transferring resources, responsibility, the course, whatever that dialogue means. But so the contracts and compacts are associated with self-determination and self-governance and the process that you're here for today. There's another term that we use in our system called direct service. Now, direct service is the same thing as the federal agency continuing to operate programs for those tribes that have decided not to assume management of their own programs. So in our system, we have direct service tribes, we have contracting tribes, and we have compacting tribes. And I think some of that terminology will be used throughout the presentation here. Another point that I heard yesterday was, what's your budget? What's the financing? Where do you get your money from? Well, our source of revenue to operate our program, I want to say by and large, used to come from the federal government, and I think it's about a 50-50 split now, but approximately 50 to 60% of our funding comes from appropriations from our Congress, so from the federal system. Our tribes, in taking over programs, have been able to leverage those resources to build private insurance, build a couple of other federal health programs that provide reimbursement for services called Medicaid and Medicare. And I would say easily today, in most of our tribal health programs, those resources are about 40 to 50% of the funding that they receive from the federal government. So our tribes have done a tremendous job of maximizing resources, but still, again, we're severely underfinanced, and that's what this graph shows. This is about a 25-year look at the Indian Health Service budget for our programs in the United States. The yellow area in the middle shows appropriations growing over the last 25 years, and it looks like we've been receiving adequate increases to maintain, current services, inflation, population growth, program increases, et cetera. But when you deflate that money for the cost of real inflation and population growth in real dollars, that's the red area. You can see that our budget has stayed relatively flat. Had we received adequate increases, that's the blue area, inflation and population growth, that's where our budget should be. So you all, as you take over management of your programs, are going to be faced with some of these same issues about how do you cover your costs, how do you organize yourself for advocacy, and some of the things. I think Ron will talk a little bit about the National Congress of American Indians and the National Indian Health Board, but start thinking about organizations such as the Northwest Portland Area Indian Health Board, the Alaska Health Board that we heard discussion on, that provide advocacy outlets for that advocacy effort with our Congress, or in your case, your Parliament. So that's kind of the financing. In terms of how this drills down to actually what you receive at the community level, or what a beneficiary that you might serve might be, for us, we have done what we call per capita cost comparisons. So we take the total budget, divide it by the the numbers of users in the system, and we come up with a per capita expenditure of federal programs. So the highest bar to my left, I think that, yeah, your left as well, is program Medicare. So Medicare beneficiaries receive approximately $6,500 per beneficiary per year. When you look at the Indian Health Service, our system, we receive about $2,100 per capita. Comparing these against other programs like Medicaid, the program we're most similar to in our system, Medicare receives about, a beneficiary in Medicare, or Medicaid, I'm sorry, receives about $4,300 per year. Again, about 50% of what someone in our system would receive. In many instances, our beneficiaries are also eligible for Medicaid, so when we're able to enroll them in Medicaid, we receive reimbursement from that program. So that's the third-party collection stuff that I was talking about. Probably one that gets a lot of people up in arms is that the bar right next to the Indian Health Service, the black bar, is what a beneficiary in the U.S. Bureau of Prisons would receive. So in the United States, we spend more on an inmate in our prison system than we do on our First Nations people. And I think that resonates a lot for most tribal leaders, for certain members of Congress. But you know, these cost comparisons are things that hopefully you're all thinking about developing, so that you can make your case when you're meeting with your government partners in developing these programs. Someone asked about a question about the budget in terms of your particular program in an area. So breaking this here breaks down the funding in our 12 administrative areas. So these are the budgets based on $2,009 of each of the areas. So yesterday, I think the Alaska question was, how much is your budget? The total money available in Alaska is about $410 million. It's a little more than that because this doesn't include 2010. But when you divide that by the number of users in the system, it might seem like a lot of money at its face, but it really isn't. And you can see there's great variation in terms of the per capita funding level across our system. One important note here is that the Alaska is $2,900, and when you compare that to, say, someone in Tucson, the very bottom one, that's $1,200 per person. The reason for that is that there's cost factors associated with delivering care in Alaska. It's not that Alaska has a whole lot more money than everybody else. They may, but when you factor in those cost variables, it probably is equivalent to the cost of delivering care in the lower 48. So I think that's an important note to make. I talked earlier about how we have some hospitals and stuff. Our system does not have inpatient hospital care across the system. So the stars on this graph or on this table here represent those systems that do not have inpatient care. So we have to provide and buy specialty care from the private sector. So this basically shows graphically what the previous table did. The system is not equal. And this became a huge issue of contention about 15, 20 years ago. And in fact, the California tribes sued the Indian Health Service. And following that, there was a decision called the Rincon case that required the Indian Health Service to go back and develop some component of addressing equity. And what was developed was what we call the Federal Disparity Index, the Federal Employee Health Plan Disparity Index. So what this does is it compares IHS funding for each of our tribal health programs relative to everybody else in the system. And the way that we did that is we developed kind of a cost benchmark using the federal employee health benefit plan, Blue Cross Blue Shield insurance products that are in that plan. And we benchmarked those to come up with an average cost per person in the course of a year. And we adjusted for differences based on, services that were available inside the IHS system, that were not available in the IHS system, that were available in the benchmark. We adjusted for third-party collection costs to a certain to a limit. And then what we ended up coming up with is we predicted that approximately $3,000 per year is what's spent on someone in the federal employee health program. And we compared that to those per capita expenditures that I show here. And what we came up with was what we call a federal disparity index. So we took the amount of money that's available in the column on the right, and we divided it by the $3,000, and we came up with an FDI score for each area. And this is what we ended up with. So you can see that, well, if you look at Alaska, it might seem like they have a lot of money, but when you adjust for inflation and all these things that are used in this benchmark process, they're only funded at about 63% of their level of need. So what you can come up with here is an index of what your level of need funding is relative to what you actually get. In the Bemidji area, they have the lowest level of need. They're only financed at about 45% of their level of need. So this gives you a mechanism by which to measure how much funding you have relative to your ability to who you have to provide services to, and it compares it across the system. It took us years to get to that point, and it took a lawsuit to finally get us to come up with some type of fairness process. I put that together in response to some of the budget or financing questions that were asked yesterday. Now, in terms of kind of our organization's been around approximately 40 years, 39 years this year. Next year will be our 40th anniversary. We were principally developed as an organization to work as liaison between the tribal programs, tribal leaders, and the federal agency in carrying out health programs. And then when 1975 came about and the Indian Self-Determination Act was passed, our role changed dramatically. We became kind of an advocacy and representation body with the federal agency to represent negotiations between tribes taking over programs from the Indian Health Service. Over the course of time, our mission has kind of evolved from that process. So we now are very active at conducting policy, budget, and legislative analysis. About 2 weeks of my time is spent probably in Washington, D.C., and the other times I'm in the state capitals working on legislative and budget issues related to programs that our tribes carry out. Our organization also carries out health promotion, disease prevention programs on behalf of our tribes. So rather than trying to establish programs individually at each tribe, a lot of times it's better just to amass that capacity with one organization, and we carry that out and we provide training and technical assistance relative to those programs and that service delivery on behalf of our 43 tribes. We also conduct data surveillance and research. So we've grown over time to being just a advocacy organization to an organization that now operates a tribal epidemiology center. We have grown, prior to the epidemiology center coming to the board, we were an organization about 10 to 12, maybe 15 employees at times. But now we've grown to an organization that's on some levels and certain times, depending on the grants and programs that we might be operating, to as many as 75 employees. Right now we're about 60 employees. And this work, the HP, the health promotion disease programs, the surveillance, the data, are all coordinated out of our epidemiology center. We are what's called a tribal organization under Public Law 93-638. That's the Indian Self-Determination Act, which allows a process for tribes coalescing together to form an organization to represent their issues. So in some aspect, we have kind of a legal standing to represent the views and positions of tribes in their health programs when we meet with our federal government. We also are a role, the National Indian Health Board is a national organization that includes a board member from each of the 12 administrative areas or the area offices of the IHS system. So we, our chairperson from our board, we send to represent us on the National Indian Health Board. So we've got a regional organization that represents our, our 43 tribes in our 3 states. There's similar organizations around the country. You heard yesterday about Alaska. And then these organizations also send a representative to sit on NIHB. And I think that's very important because we're very connected. We're very glued together in the course of our process when trying to speak with one voice. We do that at the regional level, and by sending representation to the National Indian Health Board, we also have that collective voice at the national level. Can you flip to the next presentation?